All right, well, welcome everyone. Today we're going to do a very brief overview of hypercalcemia and specifically talk about some of the things that you're going to need to know on your board examinations and also for hypercalcemic emergencies, which you may see in the hospital setting. So hypercalcemia, like anything, can be a really big topic, but we're going to try and pare it down to just the bare basics of what we need to know. So let's talk about hypercalcemia and let's talk about PTH first, okay? So when you have low calcium levels or you have high phosphorus levels, right, then that's going to be one of your big stimuluses for PTH, okay? Now, PTH is going to work in 3 different places. Can you think of those 3 different places while I write them up? So the first place it's going to work is your bone, right? It's going to break down bone. That's going to increase your calcium levels, okay? The second place is going to be your kidneys, and it works at the proximal convoluted tubule to reabsorb calcium there. Increase calcium. This actually will increase your phos as well. And this will actually serve to decrease your phos because you'll excrete it at the kidney, the proximal convoluted tubule. And then the last place is your small intestine, okay? So the way that it works here is PTH actually stimulates one alpha hydroxylase. And if you remember, one alpha hydroxylase takes 25 vitamin D, which is your storage form in your liver, and converts it to 125 vitamin D in the kidney. This is calcitriol, okay? 125 vitamin D is calcitriol. So PTH actually stimulates that, okay? And what 125 vitamin D does is it works at the small intestine to reabsorb calcium and it reabsorbs phosphorus, okay? So low calcium or high phos will stimulate PTH release. It'll work on the bone to break down bone. It'll work on the kidney to reabsorb calcium at the proximal convoluted tubule, and it'll work at the small intestine, and it does that through activation of 1-alpha hydroxylase. 1-alpha hydroxylase creates 125 vitamin D. 125 vitamin D then reabsorbs calcium and phosphorus from the small intestine. Okay? All right. So now that we have that very brief overview, remember, this is going to be very brief. What do we need to know for boards? What do we need to know for rounding? Is how do we treat hypercalcemia in the hospital setting, all right? So if we come over here, we know that when we see patients with hypercalcemia in the hospital setting, it's not a good thing. And we all know very different mechanisms for why patients get hypercalcemic, but we're gonna be talking about it, which is mostly from hypercalcemia of malignancy, okay? So hypercalcemia, so a calcium level over 14, this is going to be an emergency, all right? This is when we really start to worry about lots of different dysfunctions that can happen in our body. So hypercalcemia over 14, that's bad. So we know we need to act quickly, all right? So there's going to be a few different things that we want to do to treat these patients. So the first thing that we want to do is we want to give fluid. Now, think to yourself here over the next 5 seconds, 10 seconds, what type of fluid do we want to give and why are we giving this fluid? So we want to give normal saline. And the reason why I didn't say lactated ringers is because lactated ringers actually has a little bit of calcium in it, about 2.7 milliequivalents per liter. That's not very much, but when we're talking about really high calcium levels, we don't want to give lactated ringers or anything with calcium in it, okay? So we want to give normal saline. We want to give a bunch of salt to this patient. So patients with hypercalcemia are typically volume depleted, and that's because the polyuria is induced by hypercalcemia. So we need to expand our volume status, right? So we give normal saline. And this also helps to exchange, by the way, sodium-calcium exchanger at the proximal convoluted tubule. So those are the 2 reasons why we're given normal saline. Exchange calcium at the proximal convoluted tubule, calcium and sodium. We want to give more sodium. And we also want to volume expand. So what I do is I'll aim for 100 to 150 cc's of urine per hour. 100 to 150 cc's of urine per hour. Okay, so that's very important. When I ask you on rounds, how much are we going to give? And you want to be able to say, give normal saline, aim for 100 to 150 cc's of urine per hour. And you can certainly look back at the patient, ask the nurse, hey, we need accurate ins and outs, and then you can adjust your normal saline for that, okay? But that's the reason why we're giving normal saline and not lactated ringers. One of the big things that people think about is to give Lasix with normal saline. And remember, these patients are volume depleted, so I actually don't want to give Lasix with my fluid. That's not going to help them, okay? Unless they're in active heart failure, then you might consider it. But because I really need to volume expand these patients, I typically won't give any Lasix for them until I overload them. But you're going to give fluid until this patient is euvolemic. Once they're euvolemic, then the normal saline can slow down and eventually stop, okay? So the second thing is you want to give calcitonin. Remember, calcitonin tones down calcium. The way you want to give this, it's by weight, so you can give something like 4 international units per kilogram. 4 IUs per kilogram. You can always look these doses up. But I give it times 1, and then I will recheck a calcium level in about 6 hours, okay? If my calcium level has gone down, I know that they're a calcitonin responder, okay? So I give it times 1, and then I check calcium in 6 hours. If it goes down, then I know that I can give it again, and I give it every 6 hours or so for about 2 days. I can't give it any more than that because of tachyphylaxis. So patients just aren't going to respond anymore. If the calcium doesn't go down with calcitonin, I don't give it again. I'll just try it once. It goes down, great. I'll continue it every 6 hours for a couple of days at the max. If it doesn't go down on that first try, then I won't give it anymore. Then the third thing that you want to give is bisphosphonate, right? And so there's many different types. Zoledronic acid seems to be the best one. This takes a while to work, right? So these are more immediate, but this takes a while to work. And so this is going to have a long-term action for you. But zoledronic acid, especially in patients who are hypercalcemia of malignancy, which is really what we're talking about right now, these are our emergency patients. This is going to be a really good long-term medication while you treat the underlying cancer, if you're able to treat that. Now, where your board exams like to trip you up on this is they'll tell you that a patient has, renal failure or, advanced chronic kidney disease or something like that. And so if I have a creatinine clearance that's under 30 or a creatinine over 3, then I really shouldn't be using zoledronic acid. And in this case, you can go with Prolia or denosumab is the other name for it. And this will be on your board exams at some point, zoledronic acid. But if I have kidney insufficiency, then I'm going to go with this. Okay? And then the last thing is if I have granulomatous disorder, right? If I have hypercalcemia because of a granulomatous disorder, so this could be lymphoma, right? They have increased 125 vitamin D as their cause, then I want to give something like prednisone, 40 milligrams for 10 days or so. Because that shuts down 1-alpha hydroxylase. And remember, when you have increased 125 vitamin D as a cause for your hypercalcemia, think malignancy, think sarcoidosis, tuberculosis, things like that, prednisone shuts down 1-alpha hydroxylase. Okay? All right, there's hypercalcemia in under 10 minutes.